very informative lecture. Yeah. So just about the triple therapy. So regarding the triple therapy and the step 4, step 5. So adding the LAMA. Now we have two triple inhaler in the market. So we have the Presentry and we have the Trilogy. So the Trilogy, they complicated the issue because they gave two strengths for the inhaled corticosteroid, while the Presentry, they gave just one strength for all the triple therapy. So regarding the Trilogy, and I had discussion with the GSK, why they have two strengths of the inhaled corticosteroid. So they have one strength of the LAMA, one strength of the LAVA, but regarding the fluticasone, they have two strengths, 100 and 200. So they rely on the CAPTAIN study, and the CAPTAIN study, they have different parameters or different outcomes. So they have one outcome related to the symptoms, so they rely on the improvement of the FEV1, and they have another also, and they have also outcome related to the asthma questionnaire and the improvement in the asthma questionnaire. So they claim that the addition of the LAMA, it led to the improvement of the FEV1 and the asthma control, while the addition of the steroid or the increase in the steroid dose, or they compared themselves, they compared the Trilogy to the Relvar. So they found actually when they increased the dose of the steroid, they actually decreased the rate of the exacerbation. So the question now is that, so when you switch from, or when you go from step 3 to step 4, so would you go with the, to the Trilogy 100 or 200? And when do you go to from 100 to 200? So what's your parameter?
هو الفكرة إنه when they did the study, we're using 3 or 4 arms. One arm is 100, other arm is 200. They achieve the same outcome. So they are the manufacture both of them actually. But the problem with 100 most of the time is not available. So sometimes in the hospital you have only available 200. So yeah, I can't use what is available. But ideally, and if I have 100, okay, I'm going to use 100 is enough. Because this is 100, it's going to achieve the same outcome, same objective of control of asthma. So ideally you have to use 100 and 200. But if in the hospital, especially government hospital, mainly the pharmacies and the private, they have both. But in government we have 200, so that's what they're going to use for patients. So I think we will stick to Trilogy 200. The other thing about Trilogy approved for asthma, Bristol for COPD only, not approved for asthma until now. But I think it's already, so Bristol COPD, Trilogy for asthma, triple therapy. The other thing is Bristol, I think, is going to be approved for COPD soon. I don't know. AstraZeneca وراها مرات بيقولوا لي بس لين قدمت الكوز. I'm getting 100 for sure. Because you don't need double dose.
So how will we switch to the 200?
I don't switch to 100. You don't need, because you're going to achieve the same outcome with 100. So switching the double dose is not going to add anything. It's going to be more side effect, more adverse effects.
Which side effects, by the way? You were talking about the side effects from the corticosteroids. Which side effects?
So if it's long term, you have side effects.
Fungal infection.
You have holes in voice, you have glaucoma, you have risk of infection, pneumothorax, pneumonia.
Let's say that the patient is still having exacerbations. If we go to their study, they found that when they double the dose, you will control more the exacerbations.
That's
So
true.
would you go to the 200 or you would go to the biologics?
I got the biology. Because if they have, actually, if the patient is severe asthma, uncontrolled, in cerebral therapy, even 100 Trilogy, and they have more than 2 exhalation per year, and this is one of the indications we should take biology. If they're genuine, is severe asthma, that's going to be critical for asthma. But on the other factor, you have to look at it as it is like But if you look from the 5 risk factors, indication, the basic approach, the still severe asthma, with our 100 Trilogy, still have more than exhalation per year. Okay, يعني you have to go for project. Or requiring more than observation مش لازم ايام ولا admission. Observation ممكن outpatient cortisone, course 5 days cortisone or 7 days. So current prednisone more than 2 courses of prednisone per year is indication for project.
You allow one addition regarding the biologics. The problem with the biologics that all the studies of the biologics they were relying on the exacerbation as a criteria. Yeah, as primary outcome, and even for the inclusion. Actually, yeah, the primary outcome. So now, what about the patients who are uncontrolled regarding their symptoms, but they are not really exacerbated? Would you consider them for biologists?
What they are doing in practice, because the right outcome of the number of observations over 52 weeks of clinical trials. Secondary outcome is quality of life, asthma control, lung function. These are the secondary outcome. So some patients they are not exacerbated, but they have uncontrolled symptoms all the year, but they don't come to hospital. They don't receive steroids. They are tolerant for symptoms, and they can manage themselves. They have action plan like this. Those patients is almost 2% exacerbated even they are not presenting to the hospital because they are really symptomatic, but they are uncontrolled. So every time you see the asthma control score is than 60. So that is still the best thing. Yeah, because they are poorly controlled, even the secondary outcome. And actually, very rare to see a patient like this. In one of the very important, she see patient يقول جيت الطوارئ وخدت كورتيزون غير ما اخذ زي كذا، بس احيانا تسال سؤال رقم مستوصف بالجنب الحي. اوكي. يمكن هذه البيشنت تعتبرها ما هي زياره مستشفى. بالضبط، اروح مثلا بالليل ياخذ جلسه محاضره رجع هذه حتى لو ما اخذ الانتيبيوتيك ولا بريدنيزون ولا شيء يعني. حتى المرض يعني requiring the extra nebulizer over 24 hours. This means music.